All right, perhaps to celebrate his birthday, we'll let the birthday boy speak.
Okay. Share the screen to have.
Do it.
All righty. So let's jump over to that one. We'll put that one into that mode. Into big mode. Cool. How's that coming through? Okay.
Good. And
Great.
we see the second slide, which is this is John, and now we
John.
have
So we'll
John,
go ahead and go to
this
that
is
slide.
John.
You can see John, and what's important about this slide is we get to see John as a happy guy, his wife Sue, and Andrew's parents in his happy space at the lab. Who would have thought that John F. Alderete would have a nemesis, this happy tie-dyed wine-drinking Southeast Washington guy? But in fact, he does. And John hates one thing. This little bug, which a lot of people have never heard of, Trichomonas vaginalis, oftentimes confused with the thing you get from eating undercooked pork. But instead, Trichomonas is the #1 undiagnosed, very curable STI, more common than chlamydia, more common than gonorrhea. It's very common, but because it's a parasite, it's very good at hiding. The diagnostic options have been pretty limited. And because it hurts you slowly, it has sort of a cumulative, non-acute symptom base over time. It's not really discussed. There's a couple journal articles that ask, are we giving enough attention to the #1 non-viral curable STI? Because it is easy to cure with a week's worth of metronidazole, which is a generic. So John started working on this, 40 years ago? And developed, when he was at the UT Health Science Center in San Antonio, the first cheap point of care CLIA-waived CDC gold standard, but it requires a vaginal swab. And some of the early coloration results, some of the feedback we've gotten from users is that the coloration can vary. So this test, while it's in the market, it's being sold by Sexui, it's a commercial success, it didn't really have the broader public health move the needle impact that we were talking about. So John went back to the lab at WSU and has been working for the last 10, 15 years on a new prototype that we're calling Sentry TV. What's great is that it's blood-based, so it works for men. It's less invasive than a vaginal swab, just a lancet and a couple drops of blood. The new platform, which I have right here, gives us some little bit better signal amplification. And we've really designed it around the WHO assured criterion for low resource use. This is a pathogen that has a disproportionate effect on communities of color, on low resource environments, both in the US and internationally. The health disparities are essentially just massive. And we'll get into what some of those are here in a second. But the idea is to have something stable, shelf stable. John has some of the antibodies that have been stable at room temperature for 5, 7 years now at this point. So something we can deploy without electricity, without cold chain requirements, without high levels of training, to really start to move the needle and focus rather on what's been the case for the diagnostics, which is confirmatory diagnostics for people who have exposure or some people who are acutely symptomatic, to population level screening and diagnosis. So let's talk about what TB actually is, the most common STI you've never heard of. In the US, globally, we're talking about 354 million new cases per year. In the US, 10 million cases annually. 85% of the time, it's asymptomatic in terms of acute symptoms in both women and men. So we could say, about 50% more common than chlamydia, which we've heard of, about 4 times more common than gonorrhea, and just massively more common than syphilis. What happens when you have it and you don't know it? Now, it doubles your cervical cancer risk, triples your prostate cancer risk. It doubles the pre-labor membrane rupture. In fact, we've seen some studies that say that TB is responsible for around 10, maybe 15% of birth complications. 3x the HIV risk, because it increases both the portal of entry, if you have it through long-term low-grade inflammation, and the portal of exit. So any of your bodily secretions are going to have a higher viral load if you also have TB. So there are estimates that TB is responsible for maybe 10 again or 15% of total HIV transmissions worldwide. So because it's very curable, it's seen as a very cost-effective way of moving the needle on public health for birth complications and HIV transmission. If anything, and John being the expert on TB would say these estimates are probably all 50 or 100% too low. Because of the lack of a scalable diagnostic, the epidemiological research can be a little patchy at times, right? That combined with a global STI explosion post-COVID, I said yesterday, but in April, the CDC reported a 32% increase in syphilis from 2020 to 2021. Just last week, they had a new report saying syphilis rates in the US were the highest in 75 years. So getting attention back to this and having a population that now has a greater knowledge of diagnostics, but are looking for things that are less invasive is where we think the opportunity lies. So our goal here is universal population screening for TB. We think that there's market expansion, just given the large numbers, particularly in East Asia and South Asia. And we're really looking at a screening that's different than other STI diagnostics. Accuracy is high. We want to have CLIA waivers and point of care with no equipment or training required. The WHO assured criterion really stands for the idea of it being affordable, pricing at $20 or lower, sensitive, and I think our sensitivity numbers might end up being a little higher as we do a few more collaborations and just have more data. Specific, user-friendly. The importance of not having cold chain requirements or not requiring electricity or internet is really important for some of these low resource environments. Some of the other diagnostics that exist, and the only other diagnostic that exists for men is a nucleic amplification test. And it requires first the $70,000 machine in addition to the $55 cartridge per, and then just deliverable to end users. So let's see, I don't know if people can see my screen or the me part. Let me swap over to that. Let me stop the share for a second and just focus on me. So here's our first prototype, and I just got these in the mail last week. It's the first one I've actually had, so it comes in a little pouch. You would put in the buffer and then the lysed blood solution here. You just wait for a few minutes, and then you get out a cartridge which either is negative with a red line for the control, or positive, a red line and a dot, which means positive. One of the nice things about this platform that we're talking about is it has the ability to have two different diagnostics on it. Right now, we're really focused on the TB diagnostic, but we look at expanding into possibly pairing it with a syphilis diagnostic, because right now in the STI space, generally chlamydia and gonorrhea come on the same platform. If we could get TB and syphilis on the same platform, then that provides a pretty unified panel approach for people.
I'd say that the prevalence of COVID self-tests really help people understand the lines. As simple as that little thing is, like, oh, I remember doing that, and 2 lines is bad and 1 line is good.
Right.
I want to share with the group that overshare with the group, if you will, that I had my physical, my annual checkup about a month or 2 ago, and it had been a while since I had any blood work done. So I asked my doctor, should I, get blood done? She's like, yeah, let me just run you. And then it was like a week or 2 after 10X, and I had just seen this, and I couldn't remember the very long-term trick of blah, blah, vaginal. It was just 2, and I had to, she's like, oh, do you mean this? I'm like, oh yeah, that one. And I said, how would you feel if a test for men were available? And she was like, well, you'd have to talk to, someone in the something or other department. And I said, no, I'm just asking you if you believe that there would be some extra value to you as a provider for better healthcare for your patients, if that were the case. And she said, I don't think so. I'm like, well, why? I heard that I did that, Marvin, so we could see. I was like, well, why? And she said, well, you don't have a vagina. And I said, yes, I know. And there's a friend who's working on one for men. And she's like, well, if women have it, then, it was almost like, well, I'm already testing half the population anyhow. So, and she didn't see like an incremental, it's so hard to detect. When you presented at 10X, I was like, oh my God, this is just so logical and simple and like, get right through. She was like, yeah, I don't know. And she didn't immediately see the value. Clearly, I didn't articulate it as well as you just did. I couldn't even remember the name of the condition. but she was not convinced.
No, and I think we see that result a lot. I think our biggest challenge is the education left. When we talk about this, the health impact is comparable to HPV, which was also seen as just a natural part of the female flora before the Gardasil vaccine. They did a huge lift. Initial approval for the vaccine was only with young sexually active women. It took several years for them to approve the vaccine for men, for being carrier partners who still don't have a reliable HPV diagnostic. They've recently kind of expanded the age range for that. And a lot of that just comes down to the original decisions back in, what was it, John, the 70s, the 60s, about which STIs would be reportable. As we have these conversations, and I think John can speak to this, a lot of people's sort of eyes start to glaze over, even though there's a pretty massive reinfection cycle with people and their male partners who might be where there's not a diagnostic and the infection is latent, so they'll get cleared and they'll get infected by their partner unknowingly. And I've had certainly the experience as we've been working on this of seeing people's eyes glaze over until we point to the newer research highlighting the kind of molecular pathway and the increased prostate cancer risk. Then all of a sudden people start to sit up and pay attention and say, well, forget about incorporating this in regular prenatal screening, which is some of the work we're doing with TTI in our economic modeling. This should be part of a regular ongoing prostate screening. And while we certainly agree with that and would love to see, again, population level screening, it is a little disheartening that type of risk is what gets people to pay attention.
Just a few things. First, TTI shout out there. So Fernanda.
Thank you.
You guys met at NX, and just for the folks
We
at home,
did.
what do you do so that they understand what reason you guys are
Yeah, absolutely. So, our mission is what we call speed to patient. We definitely, I would say over 90% of our portfolio, it's really focused on medical devices and helping companies like many of you guys here to commercialize their products. I would say, our really sweet spot, it's within reimbursement and health economics. We also do pre and post FDA clinical studies. There's a lot, but again, reimbursement and health economics tends to be the entry point, which is something that investors are looking for, and they really need to know what that strategy is. Exactly.
Second thing, so thank you for that shout out.
Absolutely.
Second is Marvin, you've been with the company for a year.
We re-engaged. I started 5 years ago. We worked for about a year and then had some trouble with protein synthesis. So disappeared for 3, moved to Alabama, and then re-engaged about a year and a half ago. Yeah.
You moved all the way to Alabama just because you had protein issues?
Well, I'm originally from Alabama. I had a farm up in South.
Okay.
So
Well, that brings us to how you met John. And John, why do you hate this thing and have devoted so much of your energy to it? Not to mention making Andrew listen to it all the time.
I appreciate the question. First of all, as Marvin indicated, it's surely one of the most neglected curable STIs worldwide, not just in our country, but worldwide. The numbers in Africa alone, for example, are just incredible. It is prevalent everywhere. And as Marvin indicated, communities of color are particularly hard hit. And it is responsible for numerous adverse health outcomes.
Why did you care?
Yeah, I started off as a very young scientist working on trichomonas because NIH, the National Institutes of Health, put out a request for applications at the time. Very little was being done. And what was being done back in the late 70s and early 80s was using really ancient techniques to study the biology of this organism. They weren't getting very far. I did my postdoctoral work at UNC Chapel Hill working on the syphilis spirochete, which is one of the most difficult organisms to study, but we did, and we're quite successful. NIH took note of that and asked me to apply for a grant, which I did, and I was successful getting it as an assistant professor at the medical school at the Health Science Center at San Antonio, and I've been studying it ever since 1980. And it's clear that it's one of the most disrespected STIs. The reason Marvin alluded to is because it's not a reportable STI. That has some history behind it. Even physicians at the time, when I was going and giving grand rounds in medical schools on trichomonas, came up to me afterwards and said, "Why are you studying this bug, wasting taxpayers' money? It's a part of the normal flora of women." And even they didn't really respect the fact that this is a sexually transmitted infectious agent that causes numerous adverse health outcomes. One of the reasons it never got a lot of traction, even in the scientific community, is because there was never a real diagnostic for it to help us really understand the incidence rates and the prevalence rates, which are enormous. So I took it upon myself basically to become a spokesperson and to publish papers on the biology and other aspects of the organism that were not known before. And I just have been passionate about studying this organism and developing the diagnostics. So my work over 40 plus years has gone from doing the basic research to understand the real biology, what's going on here in an infection, to taking that knowledge base and applying it to produce something like a diagnostic point of care. I am not interested in nucleic acid amplification tests. Yes, they work. They're very good, very specific, but they require equipment, trained people, and they're only for high resource countries or regions like ours. And even in our country, rural areas, which are losing a lot of their healthcare clinics and doctors, don't have access to even PCR-based nucleic acid amplification tests for any of the STIs. So there's a real need for the kind of tests that we have developed and are trying to commercialize. And that frankly will lead eventually to an over-the-counter test, which I think is where it has to go ultimately. So yes, I began working with it, fell in love with the organism. It's really quite a beautiful organism to look under the microscope when you see it moving. You know, there are features about it that are unique to this organism that are not found in other infectious diseases, including other STI agents. And one of the most important features that I should mention is that just like our fingerprint is unique to us, we discovered the fingerprint for the organism, Trichomonas vaginalis. It happens to be this protein called actinin. And this protein is very immunogenic, which means if you're exposed to this organism, you will make serum antibody, and lots of it. And both women and men are known to make serum antibody. And because it's the organism's fingerprint, it's not found in any other organism, including humans, in the world. And so if you have antibody here, you have the bug or have been exposed to the bug. And we need to look deeper into what kind of an infection or problems you may be having that you don't know you will get down the road.
I just shared your LinkedIn URL with the group, and I'm actually going to share my screen because if you don't mind a little bit of early Friday morning praise, this is really quite a resume you have, and all of the publications you have on this. And do you still teach full time?
I teach one semester a year, yes. I teach epidemiology, and I like it, enjoy it.
Yeah, I would think so, to have that kind of dedication to it. I'm fascinated by what you said. And Rick, while I know your hand has been raised, I just want to give the group a chance, if there's anyone in general, or something that John just said, or how we came to focus on that, or just in general, if you had any comments that you wanted to share with the group. Not even you, Andrew?
Well, I keep hearing about this, but I'm not hearing enough about the problems that people have, the symptoms. You said something about the cancer, prostate cancer, that usually gets men to actually care about doing some of this stuff. And that's what I've seen a lot of more research done when it affects men more than women, even though this seems to be something that can cause major issues with women. So I'm hearing nebulous symptoms, but not specific ones. And I don't understand why you're using a dipstick technology that looks so different. Is that just because it's for the blood, or what's with that? I'm sorry. That was two questions, and I was just wondering.
It's actually several questions embedded in your questions, and I do appreciate them. Let me speak to symptoms first of all. The issue with the relationship between this STI and prostate cancer is relatively new, and because of that, there are some, even in the OBGYN clinician community, that still haven't come on board to believe that this is in fact the case. However, that said, if you look with just the last 5 years at the literature, which is replete at the molecular level, showing that there is, in fact, a bona fide relationship between this organism and its ability to initiate prostate cancer progression, at least in the laboratory. And I think ultimately, I believe this will turn out to be real. So even in this aspect, it will take some time to get some traction. With respect to women, if you look at the old literature, what you read or even will hear is that women will have a robust discharge, smelling discharge, irritation, discomfort, that is not unlike, for example, what you would experience with gonorrhea or chlamydia. That's what you read, but that's not true. And even the current literature is showing that even among at-risk populations, 85–90% of both men and women are completely asymptomatic. Now, what comes from an infection with this asymptomatic STI? What is known for a fact is that you will have an adverse pregnancy outcome, meaning an adverse rupture of your membrane, preterm delivery, low birth weight infants, which comes with its own sequelae. Infertility is a big issue here. Marvin indicated the increased susceptibility to cervical cancer, increased susceptibility to chlamydia infections, to HIV. All of those are part of what you get with this STI. Those are in fact real and supported by the literature, both past and present. What else might I be able to add to this particular issue? The reason for this type of test is that the first test, the awesome test, works only for women, not for men. It doesn't work on urine. You need a vaginal swab, which means it's invasive. And the focus groups that I have attended inform me that women would prefer a non-invasive test. A lancet prick on a finger is not considered an invasive test. We know that if you have this infection, you will make serum antibody, both men and women. And we know that it just takes 1 drop of blood to give you a result if you're positive. This is not considered a lateral flow immunochromatographic test like the awesome test. This is just a vertical technology flow assay that is just very fast, very robust, and it works. And the paper that we published actually that came out January 2nd of this year in the journal Pathogens basically highlights all of the aspects of this test that people need to know. The assured criteria by the World Health Organization is extremely important. And once again, our rural America is suffering right now from the absence or lack of, or the discontinuing medical care community. And even there, this test will become extremely important for people. So this is, even though we're considered a high resource country, it doesn't mean we don't have low resource environments. And this is, I think, the first test that with the WHO assured criteria fulfilled can then lend itself to become well established and used throughout the world, most especially in low resource environments.
Rick, you've been very patient. What do you have to contribute?
Well, I didn't even know if I should save this question until more toward the end, but if I look like I'm reading a question, I try and write these things down so I don't ramble too much. But
how's that working for you?
Not well. So I live in a large city in San Antonio, 7th largest city in the United States. And yet still we're not out in the country, but we still have a lot of people who are really unaware of a lot of the things that are going on. medically that they should do for themselves. And I also come across a lot of men who are protective of their significant others, and women in general, almost to an obsessive degree. And I wonder if it would be productive to seek out those groups, those online organizations, and get the men involved in a letter writing campaign. It can even be something where you get a form letter and you get to fill it out and customize it and send it into the administrators or the senators or whoever, in order to make this or the regulators, in order to make this three things. Number one, a reportable STI. Number two, make known that there is a diagnostic for men and women. And number three, get the diagnostic into standard care as a standard recommended thing. Because any guy I know who is going to have his standard physical would want to make sure that he didn't have anything that he was going to be passing on to somebody that he loved. And even in the communities where there's a lot of sexual activity going on, where people aren't necessarily married, a lot of these people still care a great deal about the people that they're involved with, and if they get regular medical care, would opt for something like this. So I just wonder, internet letter writing campaign, communication, things like that, just to get people generating awareness.
I'm highly skeptical of the letter writing campaign to affect this kind of change personally. I don't know how Marvin and John and Andrew, you feel about that, if you've ever attempted that route.
Well, I mean, I think this is part of the reason why Marin connected us with you, Joe, in terms of we are very aware that there's a pretty big marketing and public health aspect to this. You know, one of the things that I bring to the table is I come into this as originally a top-down investment analyst. So that type of communications work and in the medical device space is something where I'm looking for recommendations, I'm looking for best practices, and I'm trying to find people who have done it before. So my ask for the group is, as we move forward, I think we have a path for what to do on the clinical front. You know, we're starting some clinical collaborations to get some validation. You know, we know how to do basic research, publish those results, and reach the scientific community. But how do we sort of reach the audience that they were able to reach with the Gardasil vaccine? You know, and all of this happens in a background where we're tremendously lucky as a society that we get to focus on the diseases and the pathogens that cause long-term harm, as opposed to the ones that cause short-term harm. But we're reaching the point where this is just the next one that's on the list. It's coming at a confluence of at-home testing, of increased sort of sexual health awareness, and people taking an active role in that, and people just wanting to, like you said, Rick, protect their partners. So I think I understand the concepts. I'm really looking for connections and advice from groups like this in terms of best practices and how to proceed, just like, you know, you've connected me with TTI for the economic modeling. To go a little further, one of the things at 10X that Gunjan said, and he was sort of representing India, is the global need, if you want to expand these medical devices into spaces like India, into spaces like South America and Sub-Saharan Africa, the starting point has to be robustness and price and scalability. And so that's where we started in terms of our design sensibility.
Maren introduced us and her hand is raised.
I thought I'd jump in for just a little bit. It's nice to see you, Marvin and John, and to meet the third member of the party. I actually had the opportunity to work with a startup company here in Seattle called Diagnostics. They were around about 5 years ago. They were doing a laminar flow methodology for detecting STDs, and they got quite a bit of interest from some of the public health sectors. So one of the other introductions I made was to one of the gentlemen who was from that company, because I think they had done quite a bit of research in figuring out how to get visibility into this. I think that there is an education part. I think the advantage that Diagnostics had, even though their technology ultimately didn't work, was that they were starting with a recognized sexually transmitted disease. And so there was more recognition that this was something that was needed, and they had a little bit of a lesser education lift on that. But I think that finding a way to get visibility and awareness that this is a real issue is, as Marvin and John have identified, one of the big issues here.
Thank you for that. Eddie, you have something
Yeah.
or another could do with that part of the body?
Sure. Hi. Actually, my question, not question, comments and questions combined are, one of the things I think you ought to first of all understand, one of the sad realities of the world of medtech. Nobody really likes to pay for a diagnostic without a solution. You may have already run into this, but I years ago I was involved with a really sexy skin cancer diagnostic, but everyone's like, well, all you're telling me is I have a problem. So a couple of things. Number one, I'm interested to know what is the level of reinfection. Is it so common and pervasive that basically, even if we treat people, they're still going to need, and although you highlighted, and I think it is a really interesting one, the idea of the HPV vaccine. Again, that is a proactive, preventative action that's taken to limit the infection in the first place. So I don't know if there's some therapeutic or preventative vaccine that you could link this up with. And, that might be a way to go. But anyway, that just some cautionary thoughts.
We had a nice chat with some of the people at Everlywell, and they're really working on some of this at-home diagnostic full panel STI screening. And one of the things that they're very excited about is that post Gardasil, particularly in very identifiable subpopulations, the MSM, men who have sex with men group, and also single women under the age of 35, you saw an increase in their full panel preventative STI screening on an annual basis from roughly 20-25%, which is where it remains for young men, to around 50%, right? And so these are people who are actively going out and saying, give me the works, doc. I want to know everything. So the question for them starts becoming, do you want this a la carte, and becomes more, do you want your panel to include everything? And what's nice for some of these at-home panel delivery systems is that they can then close the folder because they have the diagnostic information and can then, with the results, provide immediate telehealth to provide the cure in an at-home situation. Again, we're talking about a cure, metronidazole, that's very well understood, very well studied, without a lot of sort of adverse impacts. So I think that route, identifying the subpopulations, college freshmen who generally get a full panel STI test as part of their recommended health screening. Because once you get the pathogen out of a subpopulation, it doesn't really creep back in. We're talking at incidence levels in the US of, we think probably around 4 to 6%. A bigger question in places like sub-Saharan Africa, where you might be talking around 25 and 30%, right? But there you might have some geographic help in terms of doing it like they've done with the guinea worm, one kind of location at a time. I think the other big game changer comes to us January 1st from California, and that California required that insurance provide reimbursement for at-home STI testing. Right? That has not been the case. Generally, that's now seen as model legislation for other states that set up their own Affordable Care Act health exchange. So that was something that Everlywell people were very excited about as being drivers of people who are a pretty identifiable group going and actively screening full panel and just being able to include that at a delta of $20 instead of a delta of 150.
Yeah, that was actually one of the areas where I was thinking about is not only insurers, but also groups like Kaiser, who are very proactive about thinking about a long-term continuum of cost. So they might say, oh, okay, it would be worth it to us to offer this to everybody in our group, because then if we can keep our closed community of people at lower risk of cervical cancer or prostate cancer, great.
Right.
Yeah, Ed, if I could comment on your comments, which I thought were spot on for various reasons. With respect to the issue of reinfections and vaccines. First of all, what is it that we know? Excuse me, we know that if you're a female and you're diagnosed with trichomonas, we can give you metronidazole or tinidazole, a brother drug, and we can cure you. But we also know that that same person can come back a month later and be reinfected. In other words, there's no immunity to this infection, even though the serum vaginal antibody response can be quite robust. It disappears and dissipates, but there's no immunity. Secondly, because of the biology of this organism and its infection in mucosal surfaces, there will never be a vaccine for Trichomonas, never. And it has to do with biology. The organism encodes for 100 proteinases. These proteinases are promiscuous. They degrade all immunoglobulin subclasses. They destroy all immune cells. So even if you have a robust immune response with B cells and T cells, they're destroyed. So there will never be a vaccine. But maybe we don't need a vaccine. What we need is a point of care diagnostic for screening large populations. And if they are positive, we can thus treat them. And in fact, that same argument goes for syphilis. We just need a very point of care test for syphilis. And if you're positive, we can just give you a big shot of penicillin and you're done with syphilis. So I think vaccines are not going to be the case for many of these STIs. And yes, reinfection is real and common among these populations where Trichomonas is embedded in the population.
Real quick, I want to let Sanjeev speak. He has to run, but he has a contribution.
John, Marvin, this is excellent. I've actually been, I've started a company called HerediX. We are developing a test for breast cancer and other women's cancers. We run into the same problem. Unless it's a men's disease, you don't get the investors, the venture capital community really joining you. And, you know, we are talking about.
Sanjeev, did you say unless it's a disease that affects men, you don't get investors?
It's very rare. It's the amount of investment which goes into women's health or something which is affecting men. It's about a ratio of about 10 to 90%.
I had no idea.
Oh yeah, I mean, even breast cancer, until they found men got it, they really didn't start doing more for women.
Well, so even right now, Jan, we have developed a blood test, but they say, well, mammography is available. Why do you need a blood test, right? And it's a pervasive attitude when we talk about, you know, low resource settings. They go, well, that affects those guys in those countries. It doesn't affect us. We don't care. They don't want to invest. And so we have to go to investors overseas to get the investment. You know, it's much harder. But, you know, getting action groups, breast cancer action groups and others is going to be important. So I think in your case, if you can get STI action groups involved, like the guys who were involved with HIV, that's going to be important in getting this awareness out there that for men, it is a problem. So now you will get people starting to take notice. But if you just talk about it as women's problem, they're not going to care as much. It's an unfortunate truth that happens today. And hopefully things will change. It is changing, but it's not changing fast enough.
Thank you for that before you had to run. Appreciate it. Ross?
Yeah, so Ed and Sanjeev have made a couple of good points. And I'm responding from actually my past life, looking at market demands and things. Although Marvin probably knows what my very first comment is going to be, which is knight takes e5.
Oh no. Yeah. That's another thing you cursed me with, Joe. Ross and I are now chess.com regular combatants. And let me just say my victory record is, it creates a divide by zero error. So.
Let me ask you, what are your rankings?
Let's see, I think I come in at around 1100 and Ross is bumping up.
I'm only like 12 or 1300, but we're both playing and learning. It's fun.
Okay, I'll take you both on. And my son just applied for a job there as a social media manager. He's very excited about it.
At chess.com?
Yeah.
How cool is that? All right. Well,
and one more thing about chess.com. Back in 2011, I met a guy on Twitter who was 17 at the time. And I kind of raised him in a way. He became my IT guy for a decade and is now a major producer at chess.com. Like, he's way outgrown me. He didn't want to go to college. I got him to go to college. He read these Java books like this. He was voracious. There we are. Sorry. What were you talking about?
So we were talking about some business stuff. I don't know, something. But my old business was all about understanding how to bring promising medical technologies to a market and get someone to pay for it. And you are in a tough spot. So Ed already talked about the value of a diagnostic is actually the value of the combined diagnostic and therapy, right? Diagnostic doesn't help anything unless you got something to do, and you've got something you could do. But if the real value is in these high prevalence, emerging, underdeveloped countries, then you are running up against this, how do we spend our dollars question, right? Is this, if we're going to do public health, is this where I would spend an incremental dollar, or do I have bigger public health issues for these women and men both, or whatever?
Right.
And that gets to be really, really tough. How do I take limited healthcare budgets and do I prioritize this over something else I could do? Is this the most pressing issue? So there are several comments came up that I was already thinking about, but maybe the other question I would have if I was the public health person is, well, if the drugs work well and I got 20 or 25% prevalence infected in my country, why not just prophylactically give everybody the drug and save the diagnostic costs? These are the kind of questions that you might have to struggle with.
Well, John was saying there is no drug. There will be no vaccine. So.
Not a vaccine. I get it. Not a vaccine, but just to wipe it out in the population by treating everybody once and knocking the incidence down to trivial amounts.
I don't think that is true. I mean, my partner says she's had it multiple times. She gets a antibiotic and then it goes away, or so she thinks. And John, does it in fact go away? Or does it linger?
It can reside in the mucosal surfaces of the vagina, even in the urethra, prostate area. But the drug is very efficacious, and there is in fact cure that's been established, and that can be then followed up by reinfection. But latency is known, but that comes with the asymptomatic nature of the disease. But if
Fernando, I'd like you to comment on what Ross said about, the supply and demand of health issues. I can just focus on so many things, and no offense to Professor Alderetti, but relative to some of the other things that we need to figure out, how much time we're going to spend on this.
How much money?
Fernando.
Ross, one of the things that there have been a few papers on sort of the health economics of this, and it has been seen as a particularly cost-effective method for HIV infection because it's responsible for such a large portion of total HIV transmissions. And those costs end up being, of course, borne across a variety of ways in some of these areas, because this is not really seen as a behavioral change. A lot of the HIV transmission changes require pretty large changes in behavior, particularly among men, which are difficult. That also leads to a problem for why don't you just sort of dose everybody and let the drug sort it out.
Right.
That approach. What's been seen when that approach has been applied is that men are particularly resistant to taking a week-long course of this, because in these populations where there's very high prevalence, they have to stop drinking for a week. So without a proof statement that they need to take that action and that they're the source of the reinfection, it's much easier, especially around sexually transmitted diseases where there's this stigma, to say, well, it wasn't me. So that proof statement becomes in some ways the call to action. So while I agree that would be a useful thing, separating out the giving large doses of antibiotics to a large population, and that can have some second order effects. Having that, the little stick that says, yes, take the pill for a week and stop drinking, that ends up being a pretty important proof statement for actual intervention.
Mm-hmm. You want to
You're absolutely right.
Fernando's perspective on that, yeah.
Yeah, no, I agree. I agree, Marvin, 100%. It's really complicated, and that's why the reinfection rate is just so high. Yeah.
I'm glad you're doing the modeling.
I had asked Sue privately if she has a PhD, and she replied all. So it wasn't like, hey, everybody, look at me. I have a doctorate in pharmacy. She was answering my direct question. But Dr. Carr, you had something to contribute.
Yeah, well, for emerging countries like Africa and India, most of their medications are still packaged in glass ampules. So my question was, are the treatments in glass ampules being shipped over there, or are they in vials?
Yeah, first of all, they're not in glass ampules, not at all, not for metronidazole. They're tablet form.
The metronidazole is tablet form, yeah.
Yeah.
But
Sue is asking because she's developed a new, it's a syringe that gets the glass shards out of ampules.
yeah, but like ampicillin and penicillin, I know that you keep it frozen. And that's still in hospitals in the US, still in glass ampules. So that was where I was going with that. And I apologize, I'm not,
It's a good point.
She's got ampule on the brain all the time, so.
all the time, yeah.
John, I have to imagine you've spent so much of your life on this. You must be like so frustrated that so little penetration or awareness persists. I don't know if you have any anecdotes about some initiative that you tried that you thought would work and you got a little bit and then it just didn't take.
That's actually a very good point. I'm not so much frustrated as I view this as a challenge. And I think that
You're one of those optimists. I fucking hate optimists. I'm envious of optimists.
I think this is something that can be, in fact, overcome. And I appreciated some of the comments that have been made by many of you. I think education is a big thing. And I think that if we find the right senator in the right committee, that deals with health issues or women issues, and then we can communicate with that particular individual, and that doesn't have to be a woman, it can be a man as well, and get them educated on this, we can make some traction and change things.
Have you identified who in Congress is an advocate or
I have not done that quite yet, as I've been just too busy in the laboratory.
in the professor? Yeah, I get it.
That sounds like a Marvin to do. That sounds.
Yes, I think that's correct.
In fact, I wonder if, I know you're still fundraising. I suppose you're always fundraising. And I know they don't come cheap, but I have a resource or two that I could introduce you to that is aligned with lobbying efforts and helping to get the ear and attention of elected officials. So if that's something you want to talk about, we could do that.
When we get there, I'll certainly reach out.
Marvin, it's your birthday.
It is my birthday.
Someone's taking you out to lunch soon, so I'm not going to keep you too much over. First, do you know what restaurant you're going to? Second, what are you in the mood for? And third is, what can we conclude here that we can give you gifts all week long with references or various expertise that we can lend to your challenge?
Sure. I think in terms of restaurant, I'm going to one of these places where you just show up and they bring you food and there are no choices being made, which is pretty much my favorite way to eat.
But there's a cuisine style.
Yeah, there's a cuisine. It's a sort of new American, which ends up being a polyglot cuisine for whatever they felt like cooking this week. So I'm excited about that. It's called Studio Kitchen here in Philadelphia, which if you've never come eaten in Philadelphia, I think it's the best food city in the US by a considerable jump. And I have lots of recommendations. I think, just coming at this with beginner mind for me, I've run into the place where understanding the whole how money works in the med devices space, that's new. And there's been a seismic shift, it seems, both with the higher interest rate environment and then the SVB failure. So having coaching and mentorship and advice for how to navigate that, I'm looking for kind of the right person to explain it like I'm 5. That's something that's important. And in terms of sort of scientific strategy, one of the things we haven't talked about, but that we're excited about, even though our focus is on this particular application for this particular STI, is that there's some pretty novel research John has done in order to develop the antibody target to build this kind of Frankenstein protein that we're using, which is highly indicative and highly immunoreactive. And it's at least possible that approach becomes generalizable across a wide array of pathogens. Now, given what happened the last time anybody said we can detect a lot of things with 1 drop of blood, I don't want to say that out loud, but it is an important
11 years goes by like that.
Right. It is an important part of kind of our asset base, and I think our long-term value as a firm. And at some point, we'll need resources to develop that thinking. And gosh, do I have no idea how you even begin that other than saying, hey, I need help. So those are the 2 things I'm thinking about. And and also restaurant recommendations in Portland, where I'll be in a few weeks.
Oh, okay.
Oregon, not Maine.
Yes.
So yeah, please reach out to me with
Are
any
you
of
going to
those
make
sorts
your
of
way
things.
over to 6 hours away from me and hang out at the Alderetti's house?
Whenever I can. John has a great wine cellar, so anytime I can pop in, spend some
Good to
time in
know.
the lab. And
Good to know. Well, on behalf of MDG and the entire medical devices group community, we wish you a happy birthday and a delicious meal at Studio
Kitchen.
Studio Kitchen. Next week, we are going to talk about something that we've never covered in any of these 175 or so episodes. Justin Bushko is going to talk about the right way to do V&V, validation and verification. So that'll be educational for me for sure, and I suspect for a number of you. For Joe Hage and Joe Hage Enterprises, this has been Joe Hage, and have a great week. Happy birthday, Marvin. Thank you, Doc.
Thanks very much, everybody.
I'm not going to be nice, Marvin,
Thank
just
you.
because it's your birthday, though.
Don't give me the game.
Thanks, everyone. Nice to meet everybody.
I'll never respect you again, Ross. All right, we'll see you.